This is going to be a lecture on SLE or lupus. SLE is a multi-system inflammatory autoimmune disease. It is a complex disorder or multifactorial origin resulting from interactions among genetic, hormonal, environmental, and immune factors. SLE typically affects the skin, joints, and membranes, renal, hematological, and neurological systems are also affected. SLE has a chronic, unpredictable course with alternating periods of remission and exacerbations. About 1.5 million people in the U.S. have SLE. Blacks, Asian Americans, Hispanics, Native Americans, and Pacific Islanders are more likely than whites to develop SLE. 90% of those with lupus or SLE are women. Most people with lupus develop the disease between 15 to 45 years old. The generalized disorder known as SLE is a chronic inflammatory connective tissue of unknown origin that affects almost every body system, including the musculoskeletal system. SLE is characterized again by those remissions and exacerbations, and it can range from mild episodic disorders to a rapidly fatal disease process. The majority of cases are diagnosed during the teenage and early adult years. Physiology and pathophysiology of SLE. Quite frankly, there's like an unknown cause of the abnormal immune response. However, there is a few more probable causes that they believe are the reasons for SLE. There's a genetic influence. There's a high prevalence among family members. There's hormonal. It could be from oral contraceptives, pregnancy. SLE tends to become worse in the immediate postpartum period. Infections are also a probable cause, including the Epstein-Barr virus, which may stimulate immune hyperactivity. Environmental factors can also contribute to SLE, including the sun, UV light, stress, chemicals, and toxins. There are some drugs that could also trigger, and those include those that make a person more sensitive to the sun, so like sulfa drugs, diuretics, tetracycline, and penicillin. Drug-induced SLE could not be confused with drug side effects. SLE generally occurs months to years after continuous therapy with a causative drug. Autoantibodies made against nucleic acids, single and double-stranded DNA, erythrocytes, coagulation proteins, lymphocytes, platelets, and other proteins. There's some autoimmune reactions directed against the cell nucleus, especially DNA. Circulating immune complexes are deposited in the basement capillary membranes of kidneys, heart, skin, brain, and joint. These complexes trigger inflammation that causes tissue destruction. Overaggressive autoimmune responses are related to the activation of B and T cells. Again, with this being an autoimmune disease, the body begins to attack itself. The severity of SLE varies widely. It ranges from a mild disorder to a rapidly progressive disease affecting many body systems. No characteristic pattern occurs in the progression of SLE. The circulating immune complexes can affect any organ. And like I stated previously, common tissues involved are the skin and the muscles, lining of the lungs, heart, nervous tissue, and kidneys. Some general problems, such as fever, weight loss, joint pain, and fatigue, may precede worsening disease activity. So, if you start having these clinical manifestations, it could signal that the disease is progressing. I think this image here on the screen really does show all of the involvement in that it is a multi-system involvement of SLE. I believe in your Lewis textbook on page 1717, you can look at this picture, but you can see that there are so many organs and systems that are affected. The integumentary system, the cardiopulmonary system, urinary, musculoskeletal, neurological, hematologic, gastrointestinal, and also the reproductive system. So let's do a little deeper dive into the body systems that are affected. So the skin, you can have vascular skin lesions, can appear anywhere, most commonly in sun-exposed areas. The rash may be the actual first symptom that you see, and that's most commonly like considered the butterfly rash. It kind of goes over the nose and down the cheeks. May be limited to skin. So there's CCLE, which is chronic cutaneous lupus, and there's like discord or round lesions on the scalp and face. There's subacute cutaneous lupus, and that's SCLE, and that's the red ring-shaped lesions where the disease is most active. And like I had stated previously, the most common is that classic butterfly rash over the cheeks, the bridge of the nose. It almost looks like a sunburn. Lesions do not scar or itch and are not thick or scaly. Oral or nasopharyngeal ulcers occur in one-third of patients with lupus, and alopecia is also common. In the musculoskeletal system, there's painful joints with morning stiffness is often the first sign or symptom. May precede the onset of multisystem disease by many years. They could have diffuse swelling, some stiffness, and it's often non-erosive. It can cause deformities such as the swan neck deformity in fingers. And later in the PowerPoint, there's actually some images that we can look at. Ulnar deviation and some hyperlasticity of joints. There's an increased risk of bone loss and fracture. Cardiopulmonary, there's lung disease, tachypnea and cough. Pleurisy is also possible. Dysrhythmias are due to fibrous of SA and AV nodes. This shows advanced disease and the leading cause of death among patients with SLE. Inflammation can lead to pericarditis, myocarditis, and endocarditis. Hypertension and high cholesterol are from steroid use needed to treat SLE. People with SLE are at higher risk for stroke, gangrene, heart attack, and coagulation disorders that cause clots in the arteries and the veins. In the renal system, 40% develop kidney problems that need treatment. Renal involvement is usually present within 5 years after diagnosis. Manifestations vary from mild proteinuria, which is the protein in the urine, to rapidly progressive glomerular nephritis. Scarring and permanent damage can lead to end-stage renal disease. The goal is to slow progression in the nephropathology and preserve renal function. Treatments for this are corticosteroids and immunosuppressive agents. We can use human monoclonal antibodies to help reduce autoantibody levels and control autoimmune disease activity. Hematologic blood problems are common due to the formation of antibodies against blood cells. Things like anemia, leukopenia, thrombocytopenia, and coagulation disorders. these are likely to be resistant to blood thinning effects of aspirin. Infection patients have an increased risk of infection. This may be due to impaired ability to destroy invading bacteria, deficient antibody production, and immunosuppressive effects of many anti inflammatory drugs. Pneumonia is the most common infection. Vaccines are safe for patients with SLE. Patients receiving corticosteroids or cytotoxic drugs must avoid live vaccines. It's just an image so you can kind of see what that butterfly rash, um, which is oftentimes like a first sign that we kind of see, is that rash over the bridge of the nose and into the cheeks. Neck deformity, this is an image that kind of shows that joint deformity that is associated with SLE. This shows the discord rash of SLE. You can see that they're like very rounded rash lesions. They're they're scaly and circular lesions. Look at some of the diagnostic studies that we look at for SLE. So, diagnosis is based on a distinct criteria, and if we really look at four or more of the criteria are present. So, there's a variety of abnormalities in blood. Antibodies, 97 people, 97% of people have anti-nuclear antibody abnormal titers. But there's no one specific test that's diagnostic, and that's the thing that we talked about before, is that autoimmune diseases, they are um, there's no one test that says, oh, absolutely, this is what you have. So there's always like this criterion that they look at and review diagnostic labs in order to make the diagnosis. Testing for anti-RNA antibodies, anti-Smith antibodies, anti-phosphoroid antibodies. So that's some of the antibody testing. Expected to identify immunological orders typical of SLE. So an increased ESR, CRP, like we spoke about before, that shows the inflammation within the body. And so they utilize those tests not just at the beginning, but they use it as a monitoring as well to monitor that disease activity and if the treatment that the person is using is effective. It's an evaluational piece. So the interprofessional care, really the goal is to manage the active disease and prevent and treat um, any complications. The major challenge is to manage that active disease, yet prevent treatment complications due to the treatment in which we're doing. Survival is influenced by age, gender, social health determinants, and having other problems and severities of disease. So we're looking at what other comorbidities does the patient have? Um, are they getting access to health care? Are they following up on their with their physician? Are they taking the medications as they are prescribed? Are they doing the things in which help to maybe really reduce the stress so that it helps to kind of keep the disease under control? Prognosis is improved with those early diagnosis and ongoing assessment, prompt recognition of any organ involvement, so disease progression, and now is it involving other organ systems within the body? And then, of course, the effective treatment plans. So again, are they following the plan that's been put in place? Are they able to take the medications? Do they have access to those medications? And are they doing things to kind of help reduce the risk of that progression? We use several different medications in the drug therapy for patients with SLE. So NSAIDs, right? So that's going to help with some mild joint pain. May need to try several to find the most effective because sometimes some work better than others for patients. We're going to monitor for GI and renal effects of long-term usage. So, we're going to look at liver function because where are NSAIDs metabolized? So we want to monitor that liver function. They have a greater risk of thrombosis. Anti-malarial drugs are often used to treat fatigue and skin and joint problems. um, Fatigue, skin, and joint problems such as flares. They monitor. Oh, one of the things, if somebody is on an anti malaria medication, they need to have ongoing eye exams because there's a higher risk for retinopathy with higher doses. Corticosteroids, we use the lowest dosage possible, um, and we taper off slowly, right? So one of the things with corticosteroids, they should not really, we try not to use them for long-term usage. But the major thing that we need to make sure of is that a patient doesn't just abruptly stop them. These would be like our prednisones, right? So you take a larger amount. Usually that first dose is more medication that gets into the system, and then it is slowly tapered off. We do not want somebody to just abruptly stop that. Immunosuppressive drugs, they help to reduce the organ damage. And with these medications, we need to make sure that we are monitoring for any toxicity or side effects of the medication. Anticoagulants, those are used to prevent any life-threatening blood clots. And topical immunomodulators. So these are for like skin conditions, serious skin conditions. Uh, this may be used for some of the like the butterfly rash that you saw previously and the discord lesions. I do want to make sure that I made something very clear, and I think I might have potentially caused you a little bit of confusion. Those discord lesions, um, they are round, they are raised, they are scaly. So I want to make sure that I made that clear so that you know that with those you can feel them, you can see them. They will have uh, a feel to them that is not smooth like regular skin. With our nursing assessment, we want to look at both subjective and objective data. Subjective, pain and fatigue, where we certainly can't measure that. That's really coming from the patient. Uh, are they able to perform their ADLs? Do they have to break them up? Are they able to do them themselves, or do they have to have somebody else to help them? Family history, health history, some stress. Are they in high stressful situations? Is there ways that we can maybe reduce that stress? What medications are they currently taking? And what kind of pain do they have? Oh, objective, we can obviously take their temperature, we can feel their skin, we can look for cyanosis, um, hypertension, weakness, any peripheral neuropathy, and of course, we can visualize those rashes. Disease flare up symptoms, fever patterns, joint inflammation, limitation of motion, location and degree of discomfort, and that fatigue. We want to monitor their weight, fluid intake and output. For several of these patients, we would do a 24-hour urine sample for protein and creatinine clearance. We want to observe for signs of bleeding. With any type of NSAID that we take, there's always a risk that prolonged usage can cause GI bleed. So we could assess that through, especially through like their stool. We can do an occult blood testing to see if there is blood in the stool. Neurological function, um, vision problems, any headaches, seizures, memory loss, personality changes, psychosis, and of course that peripheral neuropathy. and planning. Um, some of the nursing diagnoses that would be appropriate for this patient: musculoskeletal problems, impaired role performance, impaired tissue integrity. Those would be some that come to mind. Planning the overall goal that we want for patients with SLE, that they'll have acceptable pain management, show awareness of and avoidance of activities that worsen the disease, and maintain optimal role function and positive self image. So, the implementation, the one thing about SLE is that there's like the unpredictability causes great challenges. So, um, there's physical, psychological, and social cultural problems that require long-term management from their healthcare team. So it's best to uh, educate and to inform the patient with SLE that overall there's a good prognosis for most people. However, patient involvement is pivotal. We need the patients involved in their care, their own care, and ways that they can reduce some of the flare-ups, and how to avoid those. So excessive fatigue, sun exposure. I certainly wouldn't tell these people to go out to the beach and spend the day, right? They want to reduce their amount of time that they're out in the sun. Emotional stress. This is easier said than done. We know that most people, when they are patients, they come to the table with a lot of other issues, uh, whether it be family, children, spousal, uh, parents, financial strains, the balancing of work and life and other responsibilities. I mean, I look at you guys and I remember back when I was in school that it was balancing keeping the roof over the head of my children, making sure there was food in the pantry. At the same time, I still had to work. I still had responsibilities with school, but I was parent as well. So all of that is like a lot of stress. And people who have lupus, this can cause a flare up from the disease. They need to avoid infection. So that hand hygiene, making sure that they are not around a lot of people that are sick. If they are, make sure that they may need a mask if they have no way around being in that environment. And uh, their medications that they're taking, they need to have um, good guidance and teaching on that. Um, with a disease flare, patient may quickly become very ill. So we would want to do some assessing of fever. Has the temperature changed? Are we trending in an upward direction? Do they now have limitation of motion? Location and degree of that discomfort. Is the fatigue getting worse? Neurological status, any vision problems, those headaches, seizures, memory loss, peripheral neuropathy. We're monitoring the input and output, collecting that 24-hour urine if that is prescribed by the doctor, and observe for any bleeding. We also want to kind of teach them some uh, relaxation techniques, uh, maybe the meditation, deep breathing, right? Taking a moment to take a breath, kind of relax the body. And of course, avoiding, I can't stress this, avoiding exposure to the sun. And if they do in fact need to be out, they need to wear sunscreen. And for sunscreen, we wouldn't want somebody to just use like an SPF of 15. They need to have the higher numbers, over 30, so that they make sure that they continuously reapply it so that they do not have any effects from being out in the sun for an extended period. SLE may face many psychosocial issues. Supportive therapies may be as important as medical treatment in helping the patient cope with the disease. Provide emotional support for the patient and caregiver. especially during a disease flare. Stress the importance of planning recreational and work activities. The young adult may find sun restrictions and physical limitations hard to follow. Help the patient develop and achieve reasonable goals for improving or maintaining mobility, energy, and self esteem. Those making decisions about marriage and career worry about how SLE will interfere with their plans. Discuss how to approach employers, teachers, and coworkers about the impact of SLE. So SLE common in women of childbearing ages. Like I had said, it's usually between like 15. They start as young as 15, right? So we're looking at early adulthood. And so these would be women that would be really in their life about getting pregnant. And the pregnancy, the treatment during pregnancy, it absolutely must be addressed. Pregnancy and sexual counseling is needed because there's some concerns regarding the hereditary aspects of SLE. Planned pregnancy when disease activity is minimal. And there's actually some drugs that may need to be stopped or switched up to 3 months before pregnancy can occur. Infertility may have occurred um, due to renal involvement, high dose corticosteroids, immunosuppressive drugs. Sometimes you'll see spontaneous abortion, stillbirths, and intrauterine growth retardations are also common. Renal, cardiovascular disease, respiratory, and CNS systems may be affected during pregnancy, and flare ups are most common in that postpartum. Right. For a patient with SLE, some of the expected outcomes is that they use some of those techniques that you've instructed them on how to preserve and conserve energy in order to complete things like ADLs, to be able to manage their lives. And again, you're talking about. I'm going to really focus more on the women to say that in their lives, the age group, you might have young children. Um, so you've got to be able to conserve that energy. So we're going to enable them and give them and arm them with some of these tools. Adapt the lifestyle to the current energy. And so that could be things like um, maybe they do a task such as laundry or something like that, and then they give themselves an opportunity to rest and relax afterwards instead of trying to complete a lot of things to where they're overly exhausted. Doing small things, a little bit of a break to rest and relax, and then pick up and do the next thing. Maintain that skin integrity with the use of topical creams so that we all know that any type of opening in the skin um, is an area that infection can occur. So we want to maintain that skin integrity. Prevent disease flare up with the use of sunscreens and limit the sun exposure. Again, it's not a low number of an SPF. We're looking at SPF of over 30, and that it needs to be reapplied. If they're outside and they're sweating, it needs to be reapplied. And that if they can limit their time in the sun, then do so. Again, I use the analogy of don't go outside and spend the day at the beach. You know, sunbathing. That would not be a positive thing, and we would deter away from that. And in addition to that, we would also explain to them that going to tanning beds would not be a viable option either. We're going to talk about Guillain-Barré syndrome. Guillain-Barré syndrome, or GBS, is what we often call it, is an autoimmune disease that occurs a few days or weeks after a viral or bacterial infection. It is rare, affecting about one person in every 100,000. It can occur at any age, but those over the age of 50 are at greatest risk. GBS is the most common type of acute inflammatory demyelinating polyneuropathy. A lot of these autoimmune diseases that the cause is unknown. It that we really don't know exactly what causes it. There are some things like precipitating events that can go along with it. So you have the cellular and humoral immune responses are likely to have a role. It does follow that viral or bacterial infection. Surgery or trauma may also trigger GBS. Um, After an infection, immune responses cause injury to either of the myelin sheath or the nerve axon itself. There is edema and inflammation of the affected nerves. The result is segmental loss of the myelin sheath with exposed nerve membranes and nerve terminals and the nodes of Randover. Transmission of nerve impulses stopped or slowed. This leads to flaccid paralysis with muscle denervation and atrophy. In the recovery phase, demyelination occurs slowly. Neurologic function returns in a proximal to distal pattern, and most GBS cases follow a bacterial or viral infection of the GI or upper respiratory infection. So, if you think back to what a nerve looks like, then you will see that, you've got this myelin sheath that goes over the nerve. It's almost like a protection. And so when this inflammation and you have this damage, it causes the impulse of the nerve to not transmit at the pace that it used to. We're actually going to see other parts of this when we later on in mobility and our concept of mobility when we talk about multiple sclerosis. So, looking at some manifestations, the main features of GBS include acute, ascending, rapidly progressive, and symmetric weakness of the limbs. The first symptoms are weakness, numbness, and tingling, and reduced muscle tone. Reflexes in the affected limbs are weak or absent, and maximal weakness is reached in 4 weeks. Autonomic nervous system dysfunction occurs, causing abnormal vagal responses such as orthostatic hypotension, which places a patient at a higher risk for falls, hypertension and bradycardia, heart block, and asystole. Bowel and bladder dysfunction, such as urinary incontinence and constipation. Pain is common. It can include muscle aches and cramps, increased sensitivity to stimuli such as touch, light, sound, taste, smell, and temperatures. Pain is worse at night and contributes to decreased appetite and sleep interference. Complications that we can see with GBS includes respiratory failure, which is the most serious. When we think about that, respiratory failure would be top of the list as far as the most serious. It occurs if the paralysis progresses to nerves that really work at the in the thoracic area. We can have upper respiratory infections um, that can occur. They can get UTIs. Um, Paralytic ileus muscles in the GI stop working and can lead to blocked intestines. Muscle atrophy, so they don't have the muscle tone or strength in which they had before. And this really affects mobility because they may not be able to support the weight. So many of these patients, at some point, they could end up in a wheelchair. Physical therapy is definitely a huge thing that we need to work with these patients so that they can not lose that muscle tone or strength. Decreased nutrition. They don't have a lot of appetite. The orthostatic hypotension that I talked about previously. So we're looking at patients that have a higher risk for falls that could cause further damage to them. Uh, some of the things that we would talk to them about is if you remember, if they go to get up, they need to give themselves a couple of minutes to kind of I don't know, I like to almost say like get their wits together so that they can rise up and not have as quickly of a drop in their blood pressure. And then we can have venous thrombosis. Those are things that we can certainly see in some of the complications that are with GBS. Diagnosis is based mainly on history and assessment. Clinical features required for diagnosis include the progressive weakness of more than one limb and decreased or absent reflexes. Electrolyte levels, liver function tests, creatinine, the ESR, and evaluation of CSF analysis help to exclude other causes. The history and physical examination, the clinical signs, we can see progressive weakness, again, of more than one limb, that decreased or absent reflexes. Um, we can look at um, the electrolytes, the liver function test, CPK. The CPK is used to rule out other diseases that could potentially be causing the same clinical manifestations or presentations. The ESR we know is a indicator of inflammation. In the CSF, we might see an increase in proteins with patients with GBS, and then a nerve conduction studies. Um, it measures how quickly a nerve signal travels along the nerves. We like to use those nerve conduction studies in a lot of things, including MS that we talk about later on, because it really does give a good determination of when the signal is sent from the brain to like the lower limbs to the feet. How long does it take for it to travel? So that's what those do. So for our assessment, we're going to look at a neurological assessment. We're going to evaluate that motor and sensory function. So we're going to do a much greater neurological assessment on these patients. Respiratory and cardiac, we're going to monitor ABGs and vital capacity. We're going to closely monitor the BP, cardiac rate and rhythm during the acute phase because of potential dysrhythmias, orthostatic hypotension, and increased or decreased BP and heart rate that may occur. If fever develops, we're going to obtain sputum and blood cultures to identify pathogens so that appropriate antibiotics can be started. Nutritional needs must be met despite possible delay gastric emptying, paralytic ileus, and potential aspiration if gag reflex has been lost. Note any drooling or increased secretions that may indicate that the gag reflex is inadequate. We might use eternal and parental feeding may be used so that we're getting the patient the nutrition that they need um, and reducing the risk of aspiration because of their gag reflex being impaired. Some of our interprofessional care, we have supportive care during like the acute phase. We want to make sure that we might need to use a ventilator if something is occurring where they're not able to breathe on their own. So that during the acute phase, that could potentially be there. ICU, they might be in there for hemodynamic monitoring. Um, we can use immuno um, modulating treatments. So a PE, that plasmapheresis, it's a plasma exchange, almost kind of like dialysis kind of thing. A high dose IV, so IVIG, it's a most effective within the first 2 weeks, and less effective after we get beyond 2 weeks of the onset of symptoms. And PE and IVIG therapies have little to no value after 4 weeks past disease onset. So as you can see, the interprofessional care, we're really looking at trying to, on the new onset of these symptoms, that we're doing everything that we can, because the longer that it has gone from the onset of the symptoms and the presentation, the poorer the prognosis. I kind of briefly told you guys in class that my step grandmother, which I didn't really view her that way, but she ended up with a GBS following what they believe to be an infection, an upper respiratory infection that she then had the flu shot, and so they feel that there was a little bit of a tie together on that. And she really was not the best compliant patient with physical therapy. She complained the pain was just too much. She did not want to really work that program very well. And she ended up with all the muscle weakness and everything. She spent the rest of her life in a wheelchair. She never regained that motor control, nor the ability to get up and walk, because it just the longer it went before she would engage in any of the treatment plans, the poorer the prognosis. And so her outcome was the rest of her life was spent in a wheelchair. So, with GBS throughout the illness, provide support and encouragement to the patient and caregivers. I mean, this could be a big, major change of life, right? So, we're going to coordinate with referrals to physical therapy so that they can get up and keep that muscle tone, right? Whether they're walking or they're actually doing the exercises to not lose the muscle strength and gain more muscle strength, will help them as they start to learn to walk again and their motor abilities. Occupational therapy, I always think of occupational therapy as being that fine motor. So things like a lot of the ADLs, brushing your teeth, brushing your hair, feeding yourself. These things that would be very important. And if they've lost muscle tone and they have a lot of muscle weakness, these would be more difficult. So working with PT and OT will help with that. Speech therapy can be utilized, especially if there's some swallowing issues that have occurred. They're able to evaluate, really put patients on different types of diets, like if they needed puree or no liquids, no straws, things like that, so they can work with them to gain some strength and to get back onto regular eating, and then some type of counseling. Counseling may help the patient to adjust to the sudden disabling syndrome and the dependence on others. For some people who have never had to depend on others to do things, this could be very difficult for them, that they're not able to do all the things that they were once able to do on their own, and now they have to ask for help. Um, we have the recovery. Recovery starts spontaneously at approximately 28 days. 80% walk independently in 6 months, and these would be the patients that have engaged in those physical therapy and occupational therapy. But to walk again, they've got to work, and it's a lot of work. And so, really encouraging patients that even small steps are better than no steps. And 60% have full recovery within 1 year. The prognosis is influenced by the age, so the older they are and some of the comorbidities that they may have, the GI infection, the rapid onset. If they're in the hospital longer than 11 days, we all know that if a patient goes in with one thing, sometimes they end up gaining something along the way, an infection, pneumonia, because they're not up and moving like they were. Um, this would be a great patient that I'd make sure that they were very much taught about using the incentive spirometer so that we can, expand those lungs and get that air in there so that we can try to prevent any type of secretions in the lungs and like like pneumonia occurring. And then if a patient has the need for mechanical ventilation, that absolutely is going to really influence that prognosis because it's very hard. If we take a GBS patient and we kind of contrast it to the COPD that we were just speaking about previously uh, in our lecture, that if they've got comorbidities and they already have an oxygen issue and now they're on mechanical ventilation and it's hard to wean them off and they haven't been up moving, there's loss of muscle tone, there's loss of weakness, their lungs are not functioning the way that they would. So this prognosis could be not nearly as good. So the healthier and the quicker that we can detect GBS and start working to improve it, the better the outcomes are for our patients.